Friends, welcome to Plexus Ortho. My name is Dr. Kanan Kumar, and today we are going to discuss about the median nerve. Median nerve is important in two subjects, both anatomy and orthopedics. A lot of questions on nerve is asked in orthopedics nowadays. Also, it's a muscle supply, its course, and the problems that can occur with median nerve are discussed, and many questions are asked on this. So you must have a clear understanding about median nerve. So before we begin any topic, we of course look at the brachial plexus, its origin. We all know the brachial plexus originates from C5, C6, C7, C8 and T1 roots. If C4 is involved, it is also called as prefixed root, and if T2 is involved, it is also called as post-fixed plexus, post-fixed brachial plexus. So the C5 and C6 combine to form the upper trunk. Right, the C7 continues as the middle trunk, C8 and T1 continue as the lower trunk. Each of these trunks divide into anterior and posterior divisions. The anterior division of the upper and the middle trunk continue to form the lateral cord. The posterior division of all the trunks continue join together to form the posterior cord, and the anterior division of the lower trunk continues as the medial cord. Now the medial, lateral and posterior cords are so named because of their relationship to the axillary artery. So the axillary artery is anterior to the posterior cord, and therefore it's called the posterior cord. The lateral cord is lateral to the axillary artery, and the medial cord is medial to the axillary artery. So basically the lateral cord and the medial cord give out a branch, and this forms an M-shaped pattern. When you see in the axillary region, it forms an M-shaped pattern. And so these parts from the lateral cord and the medial cord combine to form the median nerve. Median nerve has contribution from all the roots C5, C6, C7 and C8 and T1. So all the 5 roots of the brachial plexus give contribution to the median nerve. This you must understand very clearly. Right. So now what is the course of the median nerve in the upper limb? In the axilla, it has no branches. In the arm as well, it has no significant branches. Remember, the ulnar nerve and the median nerve have no significant branches or no main muscular branches or cutaneous branches in the arm. It's the radial nerve that has multiple branches in the arm, and the musculocutaneous nerve that has multiple nerves in the arm. At the level of the cubital fossa and just below it, about 2 to 3 finger breadth below the level of the elbow joint, it gives away a major branch called as anterior interosseous nerve. All of us know the anterior interosseous nerve is a major branch of the median nerve which arises just about 2 to 3 finger breadths below the level of the elbow joint. It supplies 3 significant muscles that you must know of. The first one is flexor pollicis longus, that is to flex the IP joint of the thumb. FDP of the index finger is mainly supplied by the anterior interosseous nerve. The third muscle is the pronator quadratus muscle. It's a very difficult muscle to test in isolation because pronator teres also causes pronation of the forearm, and pronator quadratus also causes pronation of the forearm. So there are 3 muscles that the anterior interosseous nerve supply. It does not have any sensory branches. The 3 muscles are flexor pollicis longus, flexor digitorum profundus of the index finger, and pronator quadratus. Okay, then the main median nerve supplies almost all the forearm muscles, including the pronator teres, flexor carpi radialis, palmaris longus, flexor digitorum superficialis. The flexor digitorum profundus, the medial half, that is for the ring and the little finger, is supplied by the ulnar nerve. The ring and little finger FTP is supplied by the ulnar nerve. So all the muscles except the following extrinsic, that is the forearm muscles, are supplied by the median nerve. That is, these are the exceptions: FDP of the ring finger and little finger, FCU, flexor carpi ulnaris. These are the only exceptions in the forearm. All the other muscles are supplied by the median nerve. Remember this. Okay. So then coming to the level of the wrist. At the level of the wrist, we have a significant sheath which is called as a transverse carpal ligament, or the flexor retinaculum, which forms a carpal tunnel. Right, we'll go a little more into detail about the carpal tunnel. Just before going into the carpal tunnel, it gives what is called as a palmar cutaneous branch. Palmar cutaneous branch arises proximal to the flexor retinaculum or transverse carpal ligament, and therefore In cases of carpal tunnel syndrome where the carpal tunnel is affected, the sensation that it provides to the dorsum, to the volar aspect of the hand is preserved. That is, the thenar eminence and the volar aspect of the palm is preserved in carpal tunnel syndrome. So once it goes down into the carpal tunnel, it gives multiple branches to muscles and also gives a digital branch. What is its digital nerve supply? It supplies the 3.5 fingers, lateral 3.5 fingers and the nail bed region as well. So it supplies the lateral 3.5 fingers including the thumb, index finger, middle finger and the lateral half of the ring finger. The medial half of the ring finger and little finger is supplied by the ulnar nerve. All of you know this very well. What are the muscles that are supplied by the median nerve? All the intrinsics of the hand are supplied by the ulnar nerve except the following. What are the thenar muscles that we know of? It is abductor pollicis brevis, opponens pollicis brevis, flexor pollicis brevis and adductor pollicis. Among these, only the adductor pollicis is supplied by the ulnar nerve and all the rest of the muscles are supplied by the median nerve. The medial two lumbricals are also supplied by the median nerve. So what are the intrinsic muscles of the hand that are supplied by the median nerve? It is all thenar muscles except the adductor pollicis and the medial two lumbricals. All muscles of the thenar muscles except the adductor pollicis and the medial two lumbricals. So let us go into detail into each of these syndromes that can happen with the median nerve problems. First is anterior interosseous nerve syndrome. Anterior interosseous nerve affects three muscles or supplies three muscles. We know that it is a flexor pollicis longus. It's a FDP of the index finger. The ulnar half is supplied by the ulnar nerve. Remember that. Then you have the pronator quadratus. So when you have an anterior interosseous nerve affection or anterior interosseous nerve problem, the patient will not be able to make the OK sign. He cannot flex at the level of the distal interphalangeal joint of the index finger and cannot flex the thumb. So he will be making something like this. He will not be able to make the complete O. This is called a positive OK sign. Positive is called a positive OK sign. Now this also has a name. This syndrome has a name. It is called a Kilo-Nevin syndrome. Kilo-Nevin syndrome is some kind of compression or palsy of the anterior interosseous nerve. Which is the most common problem or most common fracture associated with anterior interosseous nerve affection? It is a supracondylar fracture of humerus in pediatric age group, where when the median nerve is like this, the supracondylar fracture, the superior fragment pokes into the ulnar median nerve and causes compression. The posterior-most structure in the median nerve is the anterior interosseous nerve, and therefore it causes anterior interosseous nerve palsy or weakness. And the patient or the child will not be able to make an OK sign, will not be able to make this complete circle because of a failure of the FDP of the index finger and the FPL. And usually once you correct the supracondylar fracture, they usually recover very well. So next we come to carpal tunnel syndrome. So basically when the median nerve enters the carpal tunnel, this is the carpal tunnel, right? So you have what are the contents of the carpal tunnel? There are 9 tendons. All of you must remember this. What are the 9 tendons? There are the 4 FDS tendons, 4 FDP tendons, and 1 FPL. The FPL also goes into the carpal tunnel. So if they may ask you an MCQ question showing all these tendons and structures and what does not enter the carpal tunnel, flexor carpi radialis does not enter the carpal tunnel, flexor carpi ulnaris does not enter the carpal tunnel, palmaris longus does not enter the carpal tunnel, right? And just before the median nerve enters the carpal tunnel, it gives away a branch as I have described. It's called the palmar cutaneous branch. It is called the palmar cutaneous branch, and this branch supplies the thenar aspect and the volar aspect of the radial half of the palm. So this nerve is not affected during carpal tunnel syndrome. So we have a differentiation between high and low median nerve palsy. In high median nerve palsy, the palmar cutaneous nerve is affected, whereas in low median nerve palsy, the palmar cutaneous nerve is not affected, and this sensation is maintained, and you will have sensory loss in these 3.5 fingers. Right. So what is the sensory supply of the median nerve? It is a lateral 3.5 fingers, including the thumb, index finger, middle finger, and the radial half of the ring finger. the sensation to these 3.5 fingers decreases or is lost in carpal tunnel syndrome. And what are the muscles that are affected? All thenar muscles except adductor pollicis and the medial two lumbricals. All thenar muscles except the adductor pollicis and the medial two lumbricals are affected in carpal tunnel syndrome or a low median nerve palsy. What are the causes of carpal tunnel syndrome that we know of? The carpal tunnel syndrome can be caused because of diabetes, it can be caused because of trauma, it can be caused because of hypothyroidism, it can be caused because of pregnancy. Any problem that causes increase in the increased component or increased content in the carpal tunnel compresses the median nerve and can cause carpal tunnel syndrome. What are the signs and symptoms? They usually have tingling and numbness in these 3.5 fingers. They have night symptoms which are very common. And what are the tests that we can do? We can do what is called as a Fallon's test, a Durkin's test. You can do a Fallon's test. You can do a Durkin's test. Then you can do a Tinel's test or a Tinel's sign examination. Look for thenar atrophy, right? So what is a Fallon's test? You ask the patient to flex both the wrist like this, palmar flex both the wrist and keep it like this for half a minute to 1 minute. If it recreates the symptoms of numbness, tingling, that indicates it is a carpal tunnel syndrome. What is a Durkin's test? You place pressure on the carpal tunnel with the thumb, with the examiner places pressure for about half a minute, and if it recreates the symptoms, it indicates carpal tunnel syndrome. Durkin's test is the most specific and most sensitive test. Most specific and sensitive test for carpal tunnel syndrome. Tinel sign is you tap just proximal to the carpal tunnel or proximal to the flexor sheath, and can cause a current shock like a tingling sensation, and this is called a positive Tinel sign. In prolonged cases of carpal tunnel syndrome, you can have thenar atrophy. All thenar muscles except adductor pollicis are affected in case of the thumb. Right? So these are the problems that can happen with carpal tunnel syndrome or a low ulnar nerve palsy. What happens in an high ulnar nerve palsy? High ulnar nerve palsy affects all the forearm muscles as well. So you'll have weakness in the flexion of the index and middle, and also sometimes in the ring finger. In failure, decrease in flexion of the flexor pollicis longus as well. And you'll have loss of sensation in the palmar side and the thenar side because of the palmar cutaneous branch is also affected. So this is how you differentiate between a high ulnar median nerve palsy and a low median nerve palsy. What are some of the other signs and symptoms that we see in a median nerve palsy? Because the abduction is lost. The abduction is lost, right? The abduction is mainly done by two muscles, opponens pollicis brevis, and it is also done by abductor pollicis brevis. If the opposition is lost, the thumb lies next to the hand, and this is called as ape thumb deformity. Okay, and the patient will not be able to flex the index finger. It's also called as benediction sign or pope sign. So these are some of the signs associated with median nerve palsy, and you must be able to differentiate between high median nerve and low median nerve palsy. So just for a brief recap, the median nerve arises from C5, C7, C8 and T1 roots. There are two branches which are given off from the lateral cord and the medial cord and joins to form the median nerve. There are no branches at the level of the arm. At the level of the elbow, just below it, 2 to 3 finger widths, it divides and gives away a major branch called as anterior interosseous nerve. It supplies the pronator teres, it supplies the FDS, it supplies the radial half of the FDP, and it also supplies the flexor carpi radialis and palmaris longus. The forearm muscles which are not supplied by the median nerve are the FCU and the medial half of the FDP. The major branch, anterior interosseous nerve, goes between the two heads of the pronator teres, and then it gives away 3 branches to the FPL, to the FDP of the index finger and the pronator quadratus. Right, and then it goes under the carpal tunnel. Before going into the carpal tunnel, it gives away palmar cutaneous nerve branch. When it goes under the carpal tunnel, it gives away multiple branches to the thenar muscles, to all thenar muscles except adductor pollicis and the 2 lumbricals. And it also gives sensation to the 3.5 fingers, lateral 3.5 fingers. The autonomous zone for the median nerve, the volar tip of the index finger. The autonomous zone for the ulnar nerve is the volar tip of the little finger, and the autonomous zone for the radial nerve is the first web space. I hope this clears a few doubts regarding median nerve for you. Please do get in touch with me if you have any queries regarding median nerve and its problems. Thank you very much.